So there's still a place for old tools, and for this presentation I first disclose I collaborate with Pulsion Medical Systems and with Cheetah Medical. Because in this session, what are we going to speak about? POCUS, VIXUS, closed loop systems, and the monitors. And we know all the monitors with so different acronyms: PICO, FlowTrack, Leosite, Pro, AQT, Niki, Nikon, Pram. But is there a place for the old acronyms, for instance, CVP or PAC? Let's start with CVP. What is the problem we have with central venous pressure? The problem comes from the fact that we know that clearly CVP does not tell us anything about fluid responsiveness. A lot of studies, many patients tell us that a given level of CVP doesn't tell us whether the patient is going to respond to fluid or not. I know that. Is that a reason for throwing CVP to the garbage? I don't think so. And I will try to show you 4 arguments why you should still measure CVP and use this old tool at the bedside. The first is that it is a very valuable marker of cardiac preload, and as such, it might be very helpful for the diagnosis of the cause of shock. Let's take a first example of a patient just on arrival in the emergency room or the ICU. There is shock, there is lung impairment with bilateral infiltrates at chest X-ray, and the temperature is slightly elevated and there is skin mottling. What is it? Septic shock or pneumonia, or is it cardiogenic shock with pulmonary edema? Likely your answer won't be the same if you know that CVP is 0, more septic shock, or 20. It is not possible to have a septic shock without fluid infusion with a CVP at 20. A very useful and reliable, by the way, marker of preload. Another way to use that is to remember that CVP is a good marker of the right cardiac preload, and it might be very useful in patients with ARES and mechanical ventilation to detect right ventricular failure. Let's take another example of a patient, for instance, on Sunday with restored blood pressure and a low PF ratio and ARDS and mechanical ventilation. And on Monday, blood pressure is low, the PF is the same, but you measure the CVP and you see that it has increased from 7 to 15, for instance. Doesn't it indicate that something is wrong with the right ventricle and that you should perform an echo to be sure that there is right ventricular failure? A very good way to detect, to suspect right ventricular failure under mechanical ventilation. Another way, which is a bit more complex to understand, to use CVP is to assess the response to fluid. I mean that a combined observation of CVP and CO in cardiac output allows you to interpret the response and the non-response to fluid. Let's go back to the physiology of venous return, because what is the question? You give 500 milliliters of fluid to this patient, for instance. There is no increase in cardiac output. What does it mean? That there is no preload responsiveness, that the ventricle did not increase cardiac output? Or does it mean that there was not enough fluid, that you should go on with fluid administration? The physiology of venous return tells us that, as we showed in this study, for instance, when you give fluid, you increase the forward pressure of the venous return, the mean systemic pressure, significantly, both in responders and non-responders. What is the difference between responders and non-responders? It is the response of CVP, of the right atrial pressure. In a fluid responder, because of the slope of the Frank-Starling curve, the mean systemic pressure increases, but the right atrial pressure, the CVP, increases to a lesser extent. The pressure gradient between mean systemic pressure and right atrial pressure increases. It means that cardiac output and venous return will increase. By contrast, in fluid unresponsive patients, the mean systemic filling pressure increases, but the CVP increases to the same extent. There is no increase in the gradient between mean systemic pressure and right atrial pressure. No pressure gradient increase, no increase in venous return, no increase in cardiac output. What does it mean? It means that in case of fluid unresponsiveness, there must be a significant increase in CVP. Otherwise, perhaps it means that there is capillary leak, that the fluid you gave was diluted in a very large vasodilated and leaking venous compartment. And in such a case, the CVP should not change. So perhaps just assessing the CVP may tell us whether or not the patient received enough fluid. Cardiac output doesn't increase. Look at CVP. If it increases to a significant extent, it means the patient is preload dependent, no need for more fluid. Otherwise, if there is no increase in CVP at all, perhaps it means there was not enough fluid, and you should go on with fluid administration. Finally, another way to use CVP is to bear in mind that it's physiologically, again, the forward pressure of the perfusion pressure gradient. I mean that blood flows from the arteries to the veins. It means that blood flow is determined by the gradient between mean arterial pressure and CVP. This is the determinant of the organ perfusion. So when CVP is elevated, in some instances, the perfusion pressure gradient decreases, perfusion is less. Perhaps it means that we should increase the target of the mean arterial pressure. By the way, the level of the CVP has been shown to be directly related to the organ function. The higher the CVP, the more likely the AKI in sepsis, as shown by this study. Perhaps it means that we should use CVP to set the mean arterial pressure. Perhaps it might be 65 if CVP is low. If there is high CVP, and even more in case of abdominal hypertension, perhaps we should set higher levels of mean arterial pressure. So please use CVP, measure CVP and use it, not to detect fluid responsiveness, but just to know more about cardiac preload and the cardiovascular status. It's the same with the pulmonary artery catheter. What is wrong with the PA catheter? Why did its use decrease that much? Likely because of these studies published in the 80s and the 90s and a bit later, showing that using the PAC doesn't change prognosis, and it's likely true. It's not a reason why we should not use it. I know it doesn't change prognosis, but again, there are some arguments for preferring the pulmonary artery catheter to other ways to monitor the hemodynamic function. First, SVO2 is very important to interpret cardiac output for sure, but please remind that when you measure it through the central venous catheter, you only have a CVO2, and it's not the same. And we have studies showing that neither the absolute values nor the changes were perfectly tracked, followed, and measured by the SCVO2. The best way is definitely SVO2. And it's not exactly the same even for following the changes in SVO2. Also, definitely the best way to measure the pressure, the diastolic pressure of the left ventricle is not echocardiography, it is the PAC. You do that every day with the E/E prime ratio if you know echo. But again, just look at the studies. The E/E prime ratio is a very unreliable way to estimate the diastolic pressure of the left ventricle. Look at these relationships between the E over E prime, past the E over EA ratio, and the PAOP. It's very bad. A given level of 5 of E over E prime could correspond to a PAOP of 5 or 15, totally different. If you want to measure precisely the left ventricular preload, please use the PAC. Of course, I know the argument, it's very invasive. There are many adverse effects. I think it's one of the reasons clinicians use less and less the PA catheter. But come on, look at the studies again. The comparison between the big study on internal jugular CVC and the PA catheter. Look, the rate of complications are low in both instances, but they are the same. It shows that the well-known side effects like knots in the catheter or explosion of the arterial pressure are very, very uncommon. By contrast, the complications of the PA catheter are the same complications as the jugular CVC, just due to the insertion of the desilet. And of course, and finally, I know prognosis isn't changed by the PA catheter, but do I really mind? You know that even the plethysmography has never shown to change prognosis, even in the operating room, even in meta-analysis, no change in outcome. But of course, you use it if you're an anesthesiologist. You use a bedside monitor every day. Did it show that it increases prognosis? No, and it costs some money. You just need it because it allows you to see more. And the same, for instance, with CT scan. Did anybody compare critical care with and without a CT scan? No. So I don't need any study showing that it improves prognosis for using a monitoring device, including the PA catheter. So you see, all tools that we, even if we use the new ones, even if we use the new fancy ones, we should always keep in mind the interest of the old tools. Thank you very much for your kind attention.